Welcome to another episode of Clinic Success Secrets, podcast where we uncover the strategies and insights that drive clinic growth and elevate patient care. I'm your host, Tomas Adwyer, founder of Clinic Success Partners, a medical digital marketing agency dedicated to helping clinics serve more patients and achieve the success that they deserve. Today, I'm thrilled for round two to welcome back Dr. Nirmal Kaur to the podcast. Dr. Kaur is the president and CEO of Syncoro Health, a board-certified gastroenterologist and a physician executive consultant. She's dedicated to improving healthcare delivery, especially in rural communities, and specializes in optimizing physician relationships through better communication, cooperation, and collaboration. In our episode today, we'll be diving deep into the nuances of chronic disease management, discussing the challenges, opportunities, and strategies for clinics looking to make a meaningful impact in this space. So I'm personally really looking forward to learning more about the state and the developments in chronic disease management. So with that being said, welcome back, Dr. Kaur.
Thank you, Tomas. Excited to be here. Looking forward to our chat.
So before we get into the chronic disease management space, for anyone here that hasn't listened to our first episode, which I will link to in the show notes, I would encourage people to get through. Tell us a bit about yourself. What's your elevator pitch with what you do with Syncoro Health?
Certainly happy to do so. I am a board-certified gastroenterologist, like you said, and I spent the first chapter of my career building out a tertiary care referral center specifically for the treatment of Crohn's disease and ulcerative colitis. And what that means for those who are not as familiar with healthcare is for patients who specifically suffer with Crohn's disease or ulcerative colitis, who require complex care, they are referred from their general gastroenterologist to a tertiary care specialist, kind of a niche specialist in the world of Crohn's disease and ulcerative colitis. And what I learned in that decade, a little over a decade of my work, is that we took really great care of patients if they could get to us. And patients started to tell me things that really stuck. Dr. Kaur, I'm going to need the cure today because I can't come back. Crohn's disease, ulcerative colitis are chronic disease conditions. We need to take care of them chronically and to see these patients every 4 to 8 weeks, sometimes that frequently. And I also started to see quite a discrepancy in the care of patients in rural communities, because oftentimes these niche specializations only exist in larger cities. And it just started to bug me, Tomas, and to quote my mom, when something bugs Nirmal, just get out of her way. Because it started to bug me so much that I decided to do something about it. And I moved into an executive leadership role at that organization to expand the health system and the tertiary services into rural communities. And it was a wild success. We were able to do this across 22 different specialties and involving over 60 physicians. And it went beautifully. And the root of it was the relationship between the community specialists or primary care doctors and the tertiary care specialists, doctor to doctor, working together collaboratively to improve each patient's care and also financially sustain both organizations, understanding that both clinical practices have an important role in taking care of this population. And it was so exciting, and I had so much fun executing that I decided to do this for the rest of the country. And through none other than fate and the power of the universe, I kept bumping into people who were perfect to help with this mission, and attracted my COO, Kent McMacken, who's retired C-suite out of the Southeastern United States and has decades of experience in executive leadership in health systems and rural healthcare, and launched Syncoro Health about 2 years ago, amassed a team of about a dozen specialty physicians to execute this at the physician-to-physician level, and appropriate administrative leadership for facilities management and analytics. And what we do, Tomas, is we come in to a health system, or we come into a state, and we take that specialty healthcare and we expand it into rural communities so that care isn't so difficult to get to. We improve access. And we improve access through technical operations that make sense for all organizations, thereby improving healthcare. And we're wildly excited to be joining you again today, and excited to dive into the details.
Love it. So, circling back then to the chronic disease management side of things,
Yeah.
before that, broad esoteric question. What is the biggest challenge in healthcare today as you see it in 2025?
I'd say the biggest challenge is access. And I want to be careful to use access appropriately. A lot of people will use the word access with regards to insurance coverage, and that's not what I'm talking about. I think our systems have made a lot of strides with insurance coverage. So I'm specifically talking about patients getting to the appropriate physician. And the reason access is the biggest challenge is multifactorial. One, physician shortages. Physicians are leaving the workforce in droves. I believe the most recent statistic is 1 in 5 physicians has a plan to depart within 5 years. And that's part of the reason I'm still a clinical practitioner, because that statistic bothers me so much. So I'm still a part-time gastroenterologist. So that's one. Secondly, and this one gets tricky, a lot of medical fields have advanced significantly, and that's a great thing. There should be drug discovery. There should be advancements in fields, and it's a beautiful thing to witness. But that means that patients require not just specialty care, but subspecialty care. For example, in my world, and in my previous world of gastroenterology only, my colleagues, phenomenal specialists in the world of liver disease or biliary endoscopy, they're not the ones to treat Crohn's, and they send the patient to me. So even though we're all board certified gastroenterologists to the rest of the world, when you are referring a patient, the patient has to see the correct tertiary specialist. That's hard to do if you live in the rural community and your community GI doctor is bombarded with very complex disease. Getting that patient to the right physician is a huge challenge. So when I say access here, I'm specifically talking about the patient who needs to drive 3 hours to see that tertiary specialist. So that's another component of access. And then we'd be remiss if we didn't mention that 30% of rural hospitals are on track to close. So if you add these things together, then patients, particularly patients in rural America, are really in a rough spot if they have a chronic condition that requires a super specialist. How are they going to get there? They might be in the ER more often. Their local ER now might be a few hours away because the ER that was a half hour away shut down. So getting to healthcare is access to healthcare, in my opinion, is the one of the biggest barriers, the biggest challenges we're going to be facing in 2025 and probably beyond, for sure.
It's a fairly heavy topic, but obviously it's, there's nobody that you could say that statistic to. And for me, what jumps out is that 30% of hospitals being due to shut down. That to me is mind boggling. Um, I don't think there's anybody that can make a case that wouldn't, that that's not a crisis. Um, Out of curiosity, what is the reason for there's obviously going to be a multitude of different causes, but what's causing these hospitals to be shutting down?
It's a great question, and the big one, number one, are the amount of expense that it costs to run a hospital, um, particularly with regards to workforce. So both nurses, physicians, and even ancillary staff, if you can't hire a physician to work full time at your hospital locally for whatever reason, maybe it's a very small city, it's difficult to recruit, then you can't offer that clinical service. Sorry, we no longer deliver babies at Hospital X because we can't get an OB here. That's an issue. So many times what happens is a hospital will hire a physician, and I'll say hire a physician through what's called locum tenens. Locum tenens pays physicians, I want to say, about 200%. There might be some out there who argue that that number is higher. So if your cost of paying your physician is significantly increased, if it's 300%, you see how you start hemorrhaging cash quickly as a hospital. The same goes for nursing. There are increasing utilization patterns of what's called traveling nurses. So say I'm a nurse and I live in a city with a decent airport or a halfway decent airport. I might be able to make a pretty good living working 1 week a month, flying out to wherever, because the payment for the traveling nurse can be 2 to 3-fold what it is being hired at your local hospital. So now the overhead for that hospital just went up significantly to pay those individuals because of these workforce shortages. So that is probably the most significant factor contributing.
And what is I don't know, this is obviously the Syncoro Health mission, but what does a solution to that look like? Obviously, you're paying massively over, not overpaying, but as you said, you can't afford to maintain a hospital because you have to fly people in, fly people out. What's the alternative that you would have in mind for this?
Sure. So from the standpoint of workforce solutions, we are able to do a couple of things. The systems that we set up can make the hospital scale up their services to a broader catchment area.
Mm-hmm.
It's actually quite simple. It's telehealth expansion. So, for example, if a hospital has a singular gastroenterologist who is in clinic 1 day a week and doing procedures 4 days a week, which is not terribly uncommon, what our team could do is scale up that doctor's ability to be effective and bring in advanced practice providers. So broadly speaking, Tomas, the integration of advanced practice providers can help with the workforce issue. advanced practice providers can offload a lot of patient care responsibilities, can, in some instances, function reasonably close to the physician themselves, can handle a lot of in-between visit care, and can honestly just make a physician's life better. There are probably physicians out there who are in that statistic of, and 5 years till I'm out of here. And bringing in an advanced practice provider and uptraining that advanced practice provider to work very well with that physician could push out that physician's retirement. My father-in-law was all set to retire at about 70, didn't end up retiring until about 80 because of such systems. He ended up moving into a system that supported him a lot better. Another decade of practice. It's fantastic for the community where he was. They benefited tremendously. He jokes around that he was just hanging out at that point, but he's still overseeing a very experienced physician. So, but integration of advanced practice providers is a huge way that Syncoro Health can be impactful in supporting physicians and maximizing and scaling up the existing physician workforce. And what Syncoro Health does is we come in and our specialists, our specialty physicians, cardiology, pulmonology, you name it, we train that advanced practice provider. It's often a 6-month learning curve to get that advanced practice provider to be in sync with that doctor, sometimes longer. And that's an investment. That is work. It's not easy to uptrain that individual. So we offload that piece for that hospital or that health system to allow them to retain their physicians, build upon their existing infrastructure, and not watch it crumble. The other half, as I was starting to mention, the telehealth clinics, say this hospital doesn't have a huge volume of we'll go back to gastroenterology because the patients can't get there. And then they employ video visits. A lot of people can do video visits from their phone or their computers, like us right now. But we have data to show that in rural communities, 38% of the population does not have good access to broadband. Isn't that crazy? 38%. Prior to COVID, we thought the number was around 10%. And when I say we, I mean the country. The United States data was about 10% of patients cannot pull off a video visit. And through COVID, we got real data, and we found that in urban communities, about 25% cannot pull it off for whatever tech literacy the issue is. But in rural communities, 38. I thought that number was astounding, but it was one of those moments that I knew it was higher than 10. I knew we knew that from our clinical experience. So when we park these telehealth outposts in rural communities, and say it's a small family practitioner office, and that doctor on Fridays does paperwork and doesn't see patients, that's an opportunity to take the specialty services from a neighboring hospital or health system and park their IT and their telehealth feed into that underutilized clinic. Very rarely do physicians see patients 5 days a week, 7 to 5. That's rare. There's usually some pocket where we could find, okay, Fridays 1 to 4, this office isn't being used, whatever it is, and feed that into the neighboring health system. Say it's 200 miles away, then that patient comes into their community, goes into that office. Hi, Mary. Hi, John. Sees their usual people that they're used to. And then, in room 5 today, is Dr. Kaur and the GI group from Hospital X in the big city over there. They're available today. And then that patient could at least do a consultation and get the ball rolling with their care. And the beautiful part about this, Tomas, is that if that specialist in the neighboring health community needs a CAT scan, needs blood work, needs whatever ancillary service done, they can order it and have it done locally. That helps that rural hospital survive when they get that CAT scan. And then the CAT scan report can be sent to the specialist. It's a communication, it's a relationship issue. That's what I was able to achieve in my prior role at a large healthcare organization. And that's what I'm trying to do for the country.
I love it. And when you say it, it's such a clear cut, simple solution.
It's very simple.
Yeah, simple and
I'm happy to share it because I think a lot of people, there might be individuals out there who hear this and say, well, why would she just give it away? It's because it's the right thing to do. So I'm happy to share that concept broadly.
Yeah. No, it's noble, but it's also, as you said, needed. Like effectively 2 out of 5 people not having access to broadband is crazy. It's nearly
It's completely crazy.
not
It's
too far
completely
off.
crazy.
Half of everybody. And then on the the topic of the chronic healthcare management, is there a discrepancy between different states, different areas where this tends to be? I know you said there's rural areas, but I mean on a state by state basis, is there any kind of discrepancy between the prevalence of chronic diseases?
There certainly is, and these data are from the Rand Corporation that I'll cite, and what the most striking piece that always grabs me is the percentage of patients who suffer from 2 or more chronic conditions. So to be specific, we're talking about diabetes, hypertension, might be chronic obstructive pulmonary disease, congestive heart failure. These are the chronic conditions that additively are exponentially worse than when you have one alone. So what strikes me the most is the percentage of patients who suffer from 2 or more chronic conditions. In urban areas of the United States, it's 16% of patients who suffer with 2 or more. In rural America, it's over 21% who suffer with 2 or more chronic conditions. And I can't help but wonder, is that discrepancy in part related to how difficult it is to access specialty care? Chronic obstructive pulmonary disease necessitates a pulmonologist. Congestive heart failure necessitates a cardiologist, who can be more difficult to find in a rural community. So there certainly is a discrepancy there between rural and urban. And we also have data, again, from the Rand Corporation to show that the southeastern United States is particularly affected by these trends. This is where the rates of chronic illness are the worst. And that is due to a lot of different things. But I think part of it is access to healthcare. One piece I do want to mention that I think kind of contributes to the vicious cycle going on here is I mentioned before, the physicians leaving the workforce at a rate of 1 in 5 on track to depart within the next few years. I think a part of that, we all talk about burnout and subpar health system of the United States. But I think a part of it is linked to access. For example, if I'm an ER doctor and the patient comes in with a exacerbation of chronic disease. And I know as the ER doctor that if the patient had just gotten in touch with their specialist a few days prior, this ER visit, this hospitalization that's happening now would have been avoided. So the ER doctors have a great lens on where healthcare is in pretty bad shape, because the patient comes in with congestive heart failure on Thursday. How you doing, Mrs. Smith? What's going on? Well, I couldn't get into my cardiologist for 2 months, and now this happened. So they're like on the receiving end of the access problem. I think that's why a lot of ER physicians really struggle with burnout, and that can lead to a pretty unsatisfying day as an ER doctor, and then a pretty unsatisfying life sometimes if you're the babysitter of these medical issues that were avoidable if because of the system's shortcomings. And we all know that are strong that ER doctors struggle with burnout at one of the highest rates of all specialties. So the suboptimal system that we have contributes to our physicians departing, and our physicians departing the workforce will worsen our already suboptimal system. Everyone has a breaking point, right? So that is something that our services at Syncoro Health mitigate.
I love that. And when it comes to obviously integrating the telemedicine and remote monitoring and so on for chronic care programs, do you tend to encounter any barriers when it comes to adopting, telemedicine and all that sort of stuff?
Certainly. I mean, a lot of any individual, any professional who's used to doing things a certain way can have a difficult time adjusting their way of doing things. I've had numerous conversations with physicians directly over the years. What are you doing to me, Nirmal? Like, are you seriously? Like, are you, this is not gonna be feasible in our world. And even the entire care team, showing that care team how it's done, opening their minds to doing something a little outside of the box. That's a challenge. And that's our specialty, is coming in and being helpful with that. So yeah, there can be resistance at every level. What I see many times, and always makes me just kind of surprised at how often it goes on, but many times I'll see leaders just try to add more volume to physicians. Oh, you see 16 patients in a day, we're just going to make it 20, and that'll fix all of this. And I always kind of chuckle because it's a matter of time before that falls apart. So that methodology is commonly used, and I think getting into the weeds of how this is going to go and how these systems do not negatively impact the physician-led care team, but have a positive impact on everybody, particularly the patient, with minimal disruption to the already overstretched physician care team. That's a challenge everywhere. That's the gap that I see. And that's what Syncoro Health solves at a very deeply interpersonal level. Most importantly, at the doctor-to-doctor level. Hopefully that answered your question.
It does. And again, I know everything you're saying, it makes so much sense rationally, and especially as you said on the doctor to doctor level. Um, I can imagine it must be incredibly lonely, incredibly difficult, especially when you're effectively out there on your own. You're in a rural area, as you said, you haven't got the resources, people just aren't coming in. You're burning money trying to fly in specialists. But again, that this new business comes over, Syncoro Health, and they provide a solution. I can imagine, as I said, it makes sense there'd be a pushback. Nobody likes to be told that their way of doing things is wrong.
I don't.
It's not, yeah. And I've no doubt you don't. I've no doubt you don't. But when you're communicating, I suppose what I'm getting at is when you're communicating with these clinic owners, I'm sure that they're they're probably asking, how has this worked for people in the past? So my question would be, do you have any examples that you could share, of this initiative being rolled out and what benefits people have encountered from it?
Certainly. The original endeavor that I led years ago, right around 2021 is when we got it started. And we did a large analysis on the impact that this had on patients. And when we were looking at what to measure, we measured patient volumes, how many people were affected. And it was one of those things that right at the end, one of the trainees kind of thought, we should measure their hospitalizations and ER visits because that's going to be impacted because we parked care out in these rural communities. We studied the impact on the rate of those individuals going to the ER or the hospital. And I distinctly recall the day we had our first meeting on the data analysis, and we all kind of teared up because we knew we were going to have an impact. We didn't know it would be this big. So I'm specifically talking about Crohn's disease and ulcerative colitis patients. That's where we were spearheaded the endeavors, where the volumes were the highest. And we wanted to study right away. So we specifically looked at that. And because the endeavor was led by yours truly, that's the clinical arena we studied. And so it all made sense. And it's myself and one colleague. At that point, we were just literally two of us, Crohn's and colitis specialists at this large organization. And here are the numbers, Tomas. 2,992 patients is the volume of patients that we studied on their rate of hospitalizations and ER utilization. And prior to our parking the clinic in this rural location, the rate of the ER hospitalization usage was 1.8. That's the prior, so 1.8 per year. You think about your life, if you're going to the ER about twice per year, that's indicative that your day-to-day is probably not so great. If you're landing in the ER twice a year, that's not so hot. So that's the pre. And the post, and we have the graphics were published in this publication as well. The post, we were able to drop that rate to 0.6. And that reduction, it was just a 2/3 reduction, basically because we got to these patients sooner. We're specialists in the treatment of Crohn's disease and ulcerative colitis. And by the way, there's an advanced practice provider involved without whom none of this would have worked because she absorbed a lot of the volume. I'd have run for the hills many months ago if it was not for her. She handles a lot. To this day, she still handles a lot. But we caught them in time. We set up the systems to have urgent clinic availability within 2 days. So if a patient called on Monday, I'm not doing so hot. I'm kind of worried I might be in the hospital soon. The secretary found a spot for the patient somewhere within the subsequent 42 hours. And now we're taking care of a much broader catchment area. And we reduced that rate so significantly. So that's the main piece of data in a pretty large population, nearly 3,000 people. And the most beautiful part, Tomas, was the direct testimonials that I hear from patients to this day. Thanks for getting me in so quickly. We were about to go to the ER. Like, please don't. How can an ER doctor can do pretty rudimentary things for Crohn's disease or ulcerative colitis. Most of the time we can avoid it. Occasionally it's necessary, but most of the time we can avoid it. You know, can't believe you made this clinic closer to my home, Dr. Kaur. We used to take an entire day off of work to drive down to see you, to bring mom down there to see you. So it was multiple individuals in the workforce who would take time off to bring the patient closer. So, yes, improving access improves outcomes. And I'm very proud to say now that I, obviously have handed off that leadership role, but one of the relationships we had begun 450 miles away, that clinic has just opened in the mid 2024. So now there are 5 rural clinics out of that endeavor that we began. Quite exciting and
That's
most
extremely exciting.
importantly, quite impactful.
Yeah, I mean, as you said, obviously on their health, but also personal lives, and also as you mentioned in our previous episode, which people should listen to, uh, uh, there's an actual legitimate economic benefit to that as well. Obviously, because people aren't taking time out of work, people having to replace them, so it's massive. No, it must be incredibly rewarding on your end. I can only imagine uh, to be the catalyst for that. Um, Bringing it up to the future, because I'm conscious of time, and we'll have to wrap it up, unfortunately, shortly. But the future. So we talked about the past, talked about how you got to where you are today. What and the benefits you've had. You've seen from people implementing your process. What you're doing today. The future. So chronic disease management. What trends do you foresee shaping chronic disease management over the next 5-10 years? How does that look beyond just telehealth?
What I see are hub and spoke models everywhere. The hubs are the large health systems, hospitals, large community practices, and they've got the fancy schmancy procedures. They've got the clinical trials. They've got all that good stuff that a lot of us are privileged to have access to, with quite a privilege. But I see spokes on that. All of those hubs would benefit from greater catchment. And the way to do that is to put spokes on their clinical services. And that is a very nuanced execution that varies by specialty. But I see a company like Syncoro Health executing that all over the country to build out this model where even a mom and pop family practice has a telehealth feed, but maybe it also has some additional services with that. Maybe the clinical trial team comes out every Monday and offers those rural patients access to an excellent sound trial that would benefit them. Maybe mobile health care, like in an RV or even a traveling van from a health system, goes out into rural communities to patients' homes and conducts that visit from that vehicle. Mayo Clinic is employing a similar model like this in throughout the state of Minnesota. I see that becoming the norm. Mayo Clinic has had tremendous success, and I give them a shout out for their work. But I think that they've always been leaders, and I see that normalizing everywhere with their example, amongst others. And I also commend the pivoting of academic publications like New England Journal of Medicine. The New England Journal of Medicine has created another segment of their journal called the NEJM Catalyst. And the NEJM Catalyst recognized the work that I previously led, which was at Henry Ford Health. NEJM Catalyst recognized that in the early spring of 2024. So I think that's what we're headed for, Tomas. And I think forward-thinking organizations like Mayo Clinic and NEJM Catalyst, amongst many others, are the beginnings of the avenues by which to get there.
Exciting times. Listen, I've found this fascinating as a whole. I can't say how much I admire what you do with Syncoro Health. As I said, you just need to drop some of the numbers. You know, the 38% of hospitals that are going to go. The amount of people that are frankly imminently leaving their careers. The amount of people that don't have access to the internet. The amount of people that, you know, was it 1.8 down to 0.6? You know, visit the ER per year. That is insane, and it's incredibly valuable work that you do for people, both from a health standpoint, from a personal quality of life standpoint, and frankly from an economic standpoint, as you said. So, personally, I just want to say how much I admire what you're doing. That's outside of everything else. And yeah, I suppose, do you have any finishing notes for anyone listening? You know, anyone that maybe this might have struck a chord for? Yeah, any message?
I think my final comments, Tomas said, thank you for the opportunity to get this message out. I think my final comments would just be that this isn't that difficult to do. I'm still in awe of the simplicity of the work that we led years ago at Henry Ford Health. And it's sometimes something that can be done with internal teams, and it's available in the NEJM Catalyst. The playbook and the instruction sheet are there. And for organizations that don't have resources to execute this type of work, I'm sure there's you look up Syncoro Health and you can find a way to contact us. But I really just cannot emphasize enough the simplicity of the hub and spoke model as compared to the massive impact and the massive gratitude and community love that you get from this type of work, which is one of the most rewarding things I've ever done. And just very excited to build upon that success and keep it going. So happy to chat with anyone as they would like.
Love it. And where can people find you if they want to reach out to you?
SyncoroHealth.com.
That's SYNCORO. Y for yellow. Or sync. If you're watching something.
My associate got me a mug, so I thought there we go, we could do that.
Perfect. Listen, Nirmal, it's been an absolute pleasure. I've really enjoyed it.
Thank you, Tomas. The pleasure is mine. Lovely to chat.